you can just show me with your show of hands, how many of you think this is the thing that we are testing in this? That is the diffusion across alveolar capillary membrane. Is it the only thing that we are testing? Or the second is diffusion across alveolar capillary erythrocyte membrane, that the CO has to enter inside the erythrocyte. Is this what we are testing? How many of you think this is what we are testing? Or the final option is diffusion across the alveolar capillary membrane into the erythrocyte and then finally binding to the hemoglobin. This is what we are testing. So in the diffusion study, what we are actually testing is the diffusion across the alveolar membrane into the capillary membrane into the plasma, then going into the RBCs, then finally binding to the hemoglobin. So this is what we are actually testing. So this diffusion study per se is basically a transfer test. So in the ATS, they usually use diffusion study as TLCO. It is basically a transfer test. So it is a very complex process. That, like I just said, the air that we are inhaling, that has to reach the alveoli. Then from the alveoli, it has to transfer through the alveolar membrane into the interstitium. Then from the interstitium, it has to transfer this capillary membrane, then into the plasma, then into the RBCs. Then it has to finally bind with the RBC, hemoglobin. That is what we are actually testing, and it is the whole process, not just the diffusion across the alveolar capillary membrane. So this is my first concept that I want to give you. What is DLCO test? Okay, it reflects the lungs' ability to transfer carbon monoxide from alveolar gas down to the hemoglobin, and it binds to the hemoglobin. It measures the volume of diffusion limited gas. The gas has to be diffusion limited, that is passing through this membrane per minute at a partial pressure difference of 1 mmHg. This is what DLCO basically is. Now the unit, since you have understood the concept, there is a gas, it is getting transferred. So we will measure it in terms of ml per unit time. So the time that we are taking into consideration is 1 minute through 1 mmHg of partial pressure difference. The gas is only going to transfer when there is partial pressure difference. We all know that. So this is the unit, and STBD is standardization of temperature, barometric pressure and dry conditions. So it's not going to vary according to the temperature, humidity, altitude. So there is standardization. So there is this complex process, and as you can see, there are a lot of determinants which can ultimately alter what we are seeing in DLCO. So there can be a lot of structural and functional properties. If we look at the structural properties, lung gas volume, what amount of gas is actually reaching the alveoli, okay? Then there is thickness and area of the alveolar capillary membrane. Obviously that is going to influence how the gas is getting diffused. The effects of airway closure. If there are airway closure, the gas they won't able to reach the alveoli, and the part of gas that is not reaching the alveoli, they are not going to get diffused. And the volume of hemoglobin in capillaries, which is supplying this ventilated alveoli. Now there are functional properties which are going to affect the DLCO. That is the absolute levels of ventilation and perfusion, and what is the ventilation perfusion matching that is happening there. The composition of the alveolar gas, whether we are inhaling that is filled with oxygen or not. The diffusion characteristics of the membrane, the concentration and binding properties of hemoglobin in the alveolar capillaries, and the carbon monoxide and oxygen tension that is present in the alveolar capillary. So a lot of factors that are ultimately having a say in what the DLCO test will ultimately say. Now we have understood this complex procedure. To simplify this procedure, we can summarize it into two key concepts. One of them is membrane conductivity, that is the whole transfer that is taking place right up to the hemoglobin, and the second will be the binding of CO to hemoglobin. These are the two factors which are ultimately deciding what the DLCO results will look like. Okay, so what is membrane conductivity? It reflects the diffusion properties of the alveolar capillary erythrocyte membrane, and the second is binding of CO to hemoglobin. Now it can be represented as a product of theta and Vc. What is theta? It is the rate at which carbon monoxide is binding with hemoglobin, and Vc is the blood volume that is reaching the alveolar capillaries. So these are the two factors through which we can summarize this concept of DLCO, and since they are working in parallel, it can be written as 1 upon DLCO is equal to 1 upon dm plus 1 upon theta Vc. Now we basically, whenever we talk about DLCO, the most commonly available test is the single breath holding method, single breath, and in that we do a breath hold maneuver for 10 seconds. That is the most commonly available type of DLCO, but it's easy to perform, it's most standardized, and it's relatively cheaper. But there are other types through which we can do a DLCO test. Just for the sake of information, there is this intra breath and rebreathing technique. Now the rebreathing technique, that is the most standardized and the most absolute, most correct value. What we do is we rebreathe at a rate of 30 per minute until the equilibrium reaches. So in once we are, why we are breath holding, we'll talk about it later also, so that the equilibrium reaches between the alveoli and the hemoglobin. So but majority of the time in 10 seconds that cannot be reached, especially in patients who are having obstructed airways which are not able to empty. So rebreathing technique is the most accurate. We do a rebreathing, there's a large bag, we have to collect a large volume of the gas until equilibrium reaches. That is the most standardized technique and most accurate technique. Another method is intra breath technique, in which we don't have to do intra breath hold. During a portion of the breath, a small amount is collected and we do. It's not very standardized, but yeah, the most commonly that we are going to see in our daily practice will be this single breath method, which is most commonly used, and in majority of the places it is the single breath method that is available. Now what is the gas mixture? There is a fixed predetermined gas which is used in DLCO. We cannot use any gas, huh? So let's talk about this gas mixture that we are doing in the. It has four components. The first is a tracer gas. The characteristics of the tracer gas should be that it should be insoluble, it should be chemically and biologically inert, and it should not be present in the body per se. Okay? Most commonly used the gas is helium at a concentration of 10%. Any other options that you know of? Methane. Methane is also used in some places. Now what is the function of this tracer gas? It has two important functions. The first important function, it is used in the determination of alveolar volume. When we'll talk about down the line, DLCO is calculated indirectly by calculating KCO and VA. We are basically in DLCO, we are not calculating DLCO directly per se. What we are calculating is VA and KCO, and these two components are then multiplied to give us a value of DLCO. So for calculation of VA, helium is used, helium dilution method. And another important function of helium is it gives us the value of CO which is already present in the alveoli. So these two important functions this tracer gas serves. Okay. Now the second component, obviously it has to be CO. It is used as a concentration of 0.3%, and it is basically diffusing from the alveoli to the hemoglobin and binds to hemoglobin. So it basically tells us about the diffusion capacity of the lungs. Okay. And there is a very important assumption during this test, that there is no CO which is already present in the patient's blood, so that there is no back pressure. The third component obviously is oxygen at a concentration of 21%, and nitrogen is used as a filler gas to fill the remaining amount, whatever is left, and to mimic the atmospheric air that is present. So when should a DLCO test be performed? What do you think? Any answer? Now one of the common concepts that we have is we associate DLCO with ILD. At least I used to do during my MD days, especially whenever a patient of ILD comes, then only we used to think about DLCO. That DLCO is related to ILD. Whenever we will see ILD, we will order DLCO. That was the only thing that we used to think about. DLCO associated with ILD, but it gives us so much more information. First is, it is used in the differential diagnosis of dyspnea. Any patient that is coming with dyspnea, see, it is giving us a lot of information, not just about DLCO that we just talked about. So whenever a patient of unexplained dyspnea comes to you and his X-ray is normal, his spirometry is normal, we can just perform a dyspnea, we can just perform a DLCO. It is a very sensitive indicator which will tell us the lung as a cause of shortness of breath, and down the window we can have an idea of whether it is obstructive, restrictive, or vascular disease. So in the work of a patient of unexplained dyspnea, DLCO has a very important role. Now the second question is obviously screening. It can be a first change that can happen in a patient of early ILD before chest X-ray or symptoms can be a fall in DLCO. So it can be a very sensitive predictor of early ILD, early emphysema, pulmonary vascular diseases, occupational lung diseases, and drug-induced lung disease. Before we can actually see a change on chest X-ray, performing a DLCO in a suspected patient with these diseases, it can give you an idea that something is wrong, and we can further investigate and evaluate that. Third, obviously, is follow-up, progression or response to the treatment. It is used in ILD patient to see the severity and how they are responding to and progression of the diseases. And fourth is obviously assessment of severity. In COPD, ILD, PH, the severity of DLCO is directly related to survival. So it is used in that. A quick take on how the test is performed. So first of all, we do a tidal. We'll see it in more detailed and exhaustive way when we do the workshop. But just to give you an overview, first of all, we tell the patient to take a few tidal breaths so that he get accustomed to the nose pin, nose clips, and all the equipment and all the tube that is inside his mouth. Then we tell the patient to take a non-forced exhalation from tidal volume to his residual volume. We want him to empty the lung, and this has to be non-forced. The maximum that the time that is given in the ERS guideline is 12 seconds. In obstructive patient, they will take a long time, prolonged time to empty their lung to reach the residual volume, and it has to be non-forced. If you are forcing, it might lead to early collapse of the small airways, so they are not getting ventilated. So this has to be a non-forced exhalation down to the residual volume. Then the third step is quick non-forced inhalation to the vital capacity of this predetermined gas mixture that we just talked about. And this process from RV to TLC, this should be done in a time of usually less than 4 seconds. But again, this has to be quick but non-forced. Okay. And the last step is, and the next step is basically to breath hold. At this vital capacity, we will tell the patient to hold this breath for a time of 8 to 12 seconds so that it reaches a equilibrium. Okay. And the next step is quick unforced exhalation, which has to be done within 4 seconds, and then this expired air is collected in a gas sampler. The initial part is discarded, which is the dead space, around 800 ml, 600 to 800 ml is discarded, and the remaining part is collected, and then there are two gas analyzers, one for CO and one for helium. We know the predetermined level because we are already asking the patient to inhale from a predetermined gas mixture. So before inhalation, what was the amount of gas, we already know, and after that we are collecting the mixture. So whatever diffusion took place, will be able to calculate based on the pre and post levels of helium and CO. This is the whole concept of the test. We can see first of all tidal breath, then we tell the patient to breathe from RV to his TLC. Ideally, it should be around 90% of the TLC. Then we tell the patient to hold his breath, and then there is a quick exhalation. Initial part is discarded, which is the dead space, and the second part we used to collect, and that is done for sampling. Okay. Now, what can be the potential problems during the breath? So, if there is slow inhalation, it will change the dynamics. It can reach the equilibrium early, or there can be transient overshoot, or there is stepwise inhalation or exhalation, or possible gas leak at the end. We are not able to properly collect the gas in the sample mixture, or the patient has not fully inspired and he is expiring more than what he took. So, these can be the potential problems during the breath maneuver, and especially during the breath hold, there should not be any Valsalva or Muller's maneuver. What it will do, Valsalva maneuver. What is Valsalva maneuver? This is forced expiration against a closed glottis. So what is it doing? How it is affecting? Anybody? So it is increasing the thoracic pressure. So if the thoracic pressure is increased, the amount of blood reaching the capillaries, that is being reduced. So that is being reduced, so ultimately the DLCO will decrease. And opposite of that is Muller's maneuver. We are inspiring against a closed glottis. So that will obviously reduce the pressure inside the lungs. It will lead to more blood flowing inside the capillaries, and that will increase the DLCO. So there should not be any Valsalva or Muller's maneuver during the DLCO testing. Now, they are standard acceptability criteria which are given by the ERS. The inspired volume should be more than 85% of the largest VC vital capacity and obtained within 4 seconds. A stable breath hold of 8 to 12 seconds. There should not be any evidence of leak or Valsalva or Muller's maneuver during the breath hold, and there should be 2 such acceptable tests at a time interval of 4 minutes. What is the repeatability criteria? 2 acceptable test reports, they should be within 2 ml per CO per minute per mmHg or within 10% of the highest one. Okay, these are theoretical things you need to go through and you should learn them. Well, now what are the precautions that we should take while doing this test in a patient? Now, no more than 5 tests should be performed in the same patient, because we are asking the patient to inhale CO. So if we are asking them to repeat the test again and again and again, so it might, although we are using a non-toxic levels, but obviously if we are increasing the numbers and we are telling him to repeat a lot of times, so it might lead to increased dangerous levels of carboxyhemoglobin in his blood. If clinically acceptable, patient should not inhale supplemental oxygen at least for 10 minutes before the test. Okay, 2 tests should be involved at an interval of at least 4 minutes, so that we are giving time for any preformed carboxyhemoglobin to leave the system. Okay, we should, if the patient is a smoker, ideally the best thing will be to abstain from smoking for 24 hours, but for smokers that can be a very big duration. So a time interval of 5-6 hours before or abstaining smoking before test should do fine with us. If we are smoking, it will lead to raised level of carboxyhemoglobin in our blood, that will give us a back pressure and that will ultimately affect the values. And in a patient with obstructive lung disease, we just discussed, a sufficient time, that is of 12 seconds, should be given so that the patient exhales from residual volume to residual volume. Exactly, he is able to empty his lung. So a proper time should be given. If a proper time is not given, he won't be able to completely fill his lung. That will ultimately affect the results of our test. And inhalation of the test gas should be maximal, which we just talked about. And we should avoid Valsalva and Muller's maneuver. Now, what are the adjustments that needs to be done? Now, these are the factors that are ultimately affecting DLCO. Demographic data, obviously we all know age, gender, height, race, and to standardize that, we need an exhaustive reference value, and that is what we are trying to find the societies and all. If there are a standard reference value including a large number of normal population, so the effect of demographic data can be minimized. Okay, so a lot of data is already there. And hemoglobin, which is a very important factor, every 1 gram fall in hemoglobin will lead to 7% fall in DLC. Okay, lung volume, obviously if the lung volumes are less, the amount of air that is reaching the lung is less, the amount of carboxyhemoglobin, the CO that we are going, that will ultimately affect the DLCO. Carboxyhemoglobin, obviously if there is back pressure, the CO is already present in the blood, the pressure difference will be less, so it is going to transfuse less. So every 1% rise in carboxyhemoglobin will lead to 1% fall in DLCO. Alveolar PCO2, if the alveolar PCO2 is raised, it is leading to increase in DLCO. Why? Anybody can say? Because obviously it is competing with oxygen. If CO is more, oxygen is less, and oxygen and CO that are going to bind at the same spot. So competition of CO with oxygen, that is there. If the CO2 is more, oxygen will be less, so CO will bind more efficiently to the hemoglobin. That's why increase in PCO2 will ultimately lead to increase in DLCO. And obviously exercise and body position, if the patient is exercising, more amount of blood is reaching the capillaries, it will affect the values of DLCO. And body position like supine and prone, but we obviously do the test when the patient is supine, so that is patient is sitting, so that is standardized, so it won't affect. Otherwise body position obviously affecting the VQ of the test, and it will ultimately affect. Now terminologies, we will talk in a bit detail about these two terms. So as I already told, what we measure in DLCO is VA and KCO, and they ultimately tell us DLCO. We're not directly talking about DLCO. So let's just understand what is VA. VA is obviously alveolar volume, and that is the alveolar volume which is accessible. That means it is actually taking part, it is reaching the alveoli and it is taking part in the diffusion. Okay, if there is a closed space like bulla or trapped lung which is not taking part in the diffusion, so they won't be calculated as Va. So Va is the accessible alveolar volume which is ultimately taking part in the diffusion process. In a DLCO test, Va represents how much of the lungs air is actively involved in the exchange of gases between the air and the blood. It is measured in DLCO using the helium dilution technique which we have already discussed. And DLCO and Va together they give a more accurate picture of lung function. So DLCO is the total amount of gas that is transferred. Now if we divide DLCO upon Va, so that will allow us to see how efficient the gas transfer is per unit of the lung volume. Okay. Now Va will always be less than TLC. TLC which we measure with body box, it includes all the volumes, that is trap, lung, bulla, even abdominal volume that is there. So it is always a part of TLC. Ideally speaking, it should be around 90%, but it will always be less than TLC. It can never be more than TLC. Now, if we minus TLC minus Va, that we measure, it gives an estimate of the poorly ventilated lung. It's easy to understand because only that part, I have already stressed that part that is actively involved in ventilation or diffusion, only that part is getting measured by the helium dilution technique, and TLC measures the whole volume that is present, whether it is actively involved in diffusion or it's not going to affect that. So a subtraction value of TLC minus Va, it is giving us an estimate of poorly ventilated volume of the lung. Now let's talk about KCO. KCO is basically the transfer coefficient of carbon monoxide. Okay, it is the rate of uptake of CO from alveoli and it reflects how well the lungs transfer carbon monoxide from air into the blood. Now it has two important components, KCO. The first one is efficiency of alveolar membrane. Okay, that is the diffusion part. How well it is diffusing right to the erythrocyte and hemoglobin. The second part is the availability of blood and its binding to the hemoglobin. So both these components will affect KCO and not just the diffusion component. Okay, there should be proper amount of capillary में blood होना चाहिए which has proper amount of RBCs and the RBC should have sufficient amount of hemoglobin. ठीक है, it has two important components and KCO is the efficiency index. Whatever alveolar capillary membrane is there which is functioning, how well it is transferring the gas. So KCO is telling us that. Now mathematical equation DLCO is basically Va into KCO. So if we write DLCO upon Va is equal to KCO, is it correct or not? It is frequently, KCO is frequently said or measured as DLCO upon Va is KCO. So it is correct or not? We commonly write KCO as DLCO upon Va. It is a very common practice that we do. So what do you think? It is correct? Now the first thing is this equation of DLCO is equal to KCO upon Va, that is just a mathematical equation to derive DLCO. That is not a multiplicative equation that x is equal to 2 into 2 is equal to 4. So it is not going to satisfy the mathematical equation in terms of that. This equation was just formed to derive DLCO. That is the first concept. So they are related, but they are not the same. We just discussed about DLCO upon Va. It just tells us the gas transfer efficiency per unit of lung volume. Okay? Is there any doubt what is DLCO upon Va? DLCO is the total diffusion capacity, and if we divide it by Va, it is just going to give us the diffusion efficiency per unit volume of the lung. Understood? Now, but KCO has much more to it. There is one aspect that is the diffusion aspect, alveolar ventilation. The second part is the amount of blood that is being given to the capillaries and how efficiently it is binding to hemoglobin. Okay? So it is more complicated than just DLCO upon Va. It includes gas exchange efficiency, but also considers factors like amount of blood in the lung capillaries and how well carbon monoxide binds to hemoglobin. So it is much more complex than DLCO upon Va. ठीक है. It is a bit difficult to understand, but I want to give you a message that DLCO upon VA is equal to KCO. That is not true. Although it is said like that, but there are other factors which are not there in DLCO upon VA, and KCO is much more complicated than that. Okay. And one way to look at it will be कि 1 unit change of DLCO upon VA is not going to produce 1 unit change in KCO. There is a non-linear relationship. With loss of volume, KCO will rise in a curvilinear fashion rather than in a straight line. So 1 unit change in DLCO upon VA is not going to produce 1 unit change in KCO. Now, if the KCO is normal, can we say that the patient is not having ILD? Yes or no? No, we cannot say that. If the KCO is normal, that the patient is having no ILD, because since in patients of ILD, what will happen is the alveolar volume will also reduce. The lungs are going to shrink in size, and with the loss of VA, the KCO will rise in a curvilinear fashion. So we might see in patients of advanced ILD whose lung volume are very less, their KCO might be normal, because whatever part of the lung that are functioning, some parts of the alveolar capillary membrane, they are destroyed, they are not taking part in the diffusion, but whatever is left, it's showing the efficiency of that part. So in cases of severe ILD, we might see a patient with normal KCO. That is because the VA was reduced and it has led to a curvilinear or exponential rise in KCO. So it was just a question that I wanted to give you. Now the other thing is, let's talk about the severity of DLCO impairment. Earlier we used to give it in cutoffs like above 80% is normal, then 60-40 mild, moderate, severe. But now the latest guidelines, they recommend using Z scores for assessing the severity of this patient. They correlate more with the mortality of the patient rather than the severity, and they vary across this demographic data. Using fixed cutoff, it varies amongst the demographic data. So now the recommendation is to use Z score. Normal value, if the Z score is more than minus 1.65, the DLCO is said to be normal. If it is between minus 165 to minus 2.5, we say the impairment is mild. Between minus 2.5 to minus 4, the moderate impairment. And if the DLCO is less than, the Z score is less than minus 0.4, we say the impairment in DLCO is very severe. Now, why are we talking about DLCO? Is it ultimately leading to a diagnosis? What do you think? Do we make the diagnosis of any disease based on DLCO? Like for diagnosing of COPD patients, we say कि we need spirometry value of less than 0.7. Then only we can make a diagnosis. So where is DLCO helping? Why are we talking about DLCO? If a DLCO is normal, can we say कि patient is not having ILD? Any disease that we can say कि since the DLCO is normal, the patient is not having any disease? No. There is no disease which is diagnosed or refuted based on DLCO value. So it has two key components. The first is कि a fall in DLCO can tell you about exercise capacity. If the patient has less than 50 DLCO, it is directly correlating with poor exercise performance of the patient. That is one thing, quality of life. The second thing is that the severity of DLCO is directly correlating with survival of the patient, be it in COPD, be it in ILD, be it pulmonary hypertension, and that is a proven fact. I'll just give you these two papers. This was published in Nature in 2024, 2 months back, which was the prognostic implication of 1 year decline in DLCO in newly diagnosed IPF patients. What they summarized was that the multivariate analysis showed that a 1 year decline of FVC more than 5% predicted and a 1 year decline in DLCO more than 10% predicted were independently associated with high risk of subsequent mortality. The prognostic impact of decline in DLCO remained significant regardless of changes in FVC, presence of emphysema, or radiographic indications of pulmonary hypertension. Therefore, serial monitoring of DLCO should be recommended because it may offer additional prognostic information compared with monitoring of FVC alone. Okay, this is an ILD. Another just quick, this was published in Chest 2021, clinical and prognostic impact of low DLCO in patients with level 1 gold 1 COPD. So what they concluded was a DLCO cutoff value of less than 60% predicted that was associated with all increased all cause mortality, and these patients when they were compared with a similar FEV1 were more symptomatic. They had low BMI, more dyspnea, lower inspiratory capacity, lower 6-minute walk distance. So DLCO is telling you these things. That is why we need to club in DLCO not just in a patient of ILD, but it has a plethora of long conditions in which we can use DLCO, and it is giving you a lot of information. Now just a quick take on interpretation. I think I have missed my time. Very quickly we will go through interpretation. What is the first step you think of DLCO? How do you start interpreting DLCO? Anyone? Look at VA, look at KCO. The first thing is to look at spirometry. That I think is the first step. You should not go back. You are looking at DLCO and then suspecting what it might be. No. Always look at spirometry first. Better to look at the body box then, and then look at DLCO. That will be the correct way. That will help you in reaching a diagnosis rather than looking at DLCO and suspecting what it might be. So the better way, and obviously you should tell the patient to perform spirometry first, then you should go with DLCO. So that is the first step. Okay, in interpreting DLCO, always the first step is look at spirometry, better to look at body box then, and the third step should be to look at DLCO rather than going backwards. So this was the algorithmic chart that was given in the latest guidelines, which are published in 2022 in the ERS guidelines. So if you are looking independently at DLCO, so obviously the first thing that you will look is whether it has at a lower limit of normal is used rather than predicted percentage. The lower limit of normal is used. If it is below 5th percentile, we say the DLCO is less. If it is above 95th percentile, we say the DLCO is high. High DLCO, obviously we all know the causes, which is increased blood flow, like in cases of left to right shunt, hyperdynamic condition of the patient like fever, exercise, asthma, obesity, polycythemia, hemorrhage, we all know. Okay, now let's focus about if the DLCO is less. The second thing that we should look at is VA, that is the alveolar volume. If the alveolar volume is normal, so we can say the major pathology is in the pulmonary vasculature. Okay, because the volume was absolutely normal. If there is ILD or any other pathology, pneumonitis, which is ultimately affecting the KCO, VA is usually reduced in that. So if the VA is normal, we can say the abnormality is mainly in the pulmonary vascular thing. Okay? Pulmonary hypertension, embolism, vasculitis. Now the next, if the VA is low, we should look at KCO. If the KCO is normal or low, so in conditions obviously we just talked about, it will, why it will be low, it is understood in patients of ILD pneumonitis due to thickness of the alveolar capillary membrane, it will be reduced, and it can also be normal. We just talked about in severe cases because of the proportionate fall of VA, it can result in normalization of KCO. Now if the KCO is high, so what it will tell, because it will tell the pathology is outside of the parenchyma. Okay, it is mainly related to the loss of either loss of lung volume like pneumonectomy or chest wall diseases, okay, which is affecting the DLCO process, that is incomplete lung expansion due to neuromuscular dysfunction or failure to take a deep breath. Okay, matlab that the pathology is outside of the lung parenchyma, it is in the chest wall mainly, or things like that. Okay, so the interpretation per se is not very difficult. Okay, and this was the earlier chart which was given in the 2005 interpretation, which was clubbing everything. This is the real way to look at DLCO. So I'll just quickly go through this. So the first thing that obviously when we look at spirometry is the FE1 upon FVC ratio. If it is low, we can say the patient is having obstruction. The second thing we should look at is we do a body box, we look at the VC. If the VC is more than the lower limit of normal, then the patient is having only obstruction. The patient is having only obstruction. Look here, and then we are going here. Okay, if the FE1 upon FVC is low, then we should look at VC, that is the total lung capacity, and if that is normal, we can say the patient is having only obstruction. So in this patient, we'll do a DLCO, and if it is more than lower limit of normal, so if that is yes, then the patient is obviously asthma or chronic bronchitis. If that is low, we can make a diagnosis of M5C. Okay? And if on the other hand, if the FE1 upon FVC is normal, then we should look at VC, that is the total lung capacity. If that is normal, matlab FVV1 upon FVC is also normal, VC is normal. So we have ruled out obstruction and restriction. Okay. If both of them are normal, then we should look at DLCO. If that is normal, the patient is normal. If that is abnormal, then the patient is having any pulmonary vascular disorders. Okay. If a patient is having FEV1 upon FVC as normal, but his total lung capacity was reduced, and if it is reduced, we can make a diagnosis of restriction, and in this patient we should do a DLCO. If it is normal, then obviously there is chest wall or neuromuscular disorder. If that is lower reduced, we can make a diagnosis of ILD pneumonitis. Okay, we'll talk about it when we talk about it more when we do the workstations. Okay, so thank you, and I've taken more time. Just a quick take home message. The first will be कि diffusion study is a transfer test. It is not just telling us about the diffusion, but the whole process down to the hemoglobin. DLCO should not be done only in ILD patients. DLCO upon VA is not KCO. It should be interpreted in combination with other pulmonary function tests, and interpretation of DLCO is easy. Thank you for your patient listening, and I hope I made some sense, and thank you for giving me this opportunity.